When I stay in Pittsburgh, and we check the cells molecule over the dendritic cell or T cell to make them connect and to shut down the immune response and make the T cell tolerance. But now we have monoclonal antibody to block this connection. So recently, there are totally 5 IO developed. And so just the professors talk about the Kino 045, and Taiwan also participated in this clinical trial. And now, Pembro or Atezo available for the first line and second line, but Nivo only for second line. Today, my topic, I will talk about the neoadjuvant. And neoadjuvant chemotherapy, I think a lot of the speaker also offer the T2 to T4A. However, he has failed to become a widely accepted treatment due to more than 50% are participating in eligible patients. And last year, there are 2 clinical trials, Pembro or Atezo, could result in pathologic complete response. In Pembro, 42%, Atezo, 29%, complete response, T0. So this makes us very amazing. And in our institute, we have initiated the neoadjuvant immunotherapy in 2 years ago. Firstly, we used for the upper tract, renal pes tumor and ureter tumor. So this case, you can see the have a renal pes tumor. Sorry. And ureter tumor, here, at least a T3. And he received 2 cycles of Pembro, 1 cycle of Nivo, but due to high fever, changed to be Pembro. You can see the renal pes tumor shrinkage, the ureter tumor shrinkage. Then we remove the kidney and ureter. And kidney, no any tumor, no any residual tumor. But the ureter tumor downstage to be T2. Okay. Okay. So, from the clinical trial for Atezo and Pembro, then we go back to check our patient. And we totally, about 70 patients have received the IO treatment in our institute. We check the patient, and before operation, if they receive the IO treatment, and totally we find 5 cases are compatible with this finding. And this is a T3, T2B, T3, T3, T2. And all these 5 patients were supposed to receive the radical treatment. But we mentioned the phase 2 clinical trial about the result. And the patient, they have the informed consent and they want to receive the Pembro, or 1 case receive a Nivo. Then we check the result. Okay, so pre-treatment PD-L1 presentation, and this very good, 60% TPS. So when we check the patient again, I show you. This was a case, and that is a T3. But after the Pembro, we check the tumor disappear, but we perform partial cysterectomy, not any tumor, T0. And the second case, T2B, but after 2 cycles of Pembro and BCG, we also instilled BCG, downsizing. So we switched to partial cysterectomy instead of radical cysterectomy. But the pathology also showed the T2. And this is a third case. at this T3 broad-based tumor. And he received 3 cycles of pembro and BCG every week for time. In this case, you can see we check the CT again, downsizing and shrinkage of tumor. But before the operation, we find still some residual tumor here, but the tumor shrinkage. So we support to perform the robotic radical cystectomy, but we changed our mind. We just perform robotic partial cystectomy. And finally, they said the tumor margin is clear. Only microscopic perivesical invasion, only microscopic. Not downstaging, but margin is clear. Lymph node or lymph node negative. And this is the first case at the T3. By this case, after the treatment IO, the tumor size almost the same. So he received a radical cystectomy and ileal content. And this is our fifth case. Tumor filled with the whole bladder. Of course, we perform TURP, then IO. And 2 months later, only a few tumors left. And we cut it out, T1. So, for such kinds of patient, maybe 2 years ago, I will radical cystectomy immediately. But now, only TURBT. So the patient very happy. Yeah. And for my first case, mycelium gravis, after the first dose of IO, he said, I cannot open one eye. And he come to see me. I said, maybe that's okay. You still have one eye open. So I inject the second dose. And I cannot open my both eyes. I'm very nervous. So I refer this patient to the Department of Neurology. But very lucky. He was admitted for 3 months, but he recovered. And only 2 cycles, tumor-free. Now follow-up more than 1 year, no recurrence. So he's very happy. Even he suffered from mycelium gravis. And I reviewed the paper, the mortality rate 30%. So very dangerous. So we must keep in mind. So that's why I say the IE may be related to the response of the IO. So if the patient have a severe IE, you will say, never mind, you will have a good response. Yeah. How about the post-treatment PD-1 expression? You can see this patient, because we cannot check, because no tumor, we don't know how to check. So this patient increase of the PD-1 expression after operation. This is the same. So this patient, yeah, still have the T3A, and this is downstaging. So we have 1 patient PT0, and 1 patient downstaging, and 3 patients keep the same staging. But all patients have the downsizing of the tumor. So we can spare the bladder. We support to perform 5 cases of radical cystectomy, but now only 1 case. Yeah. And their follow-up has been more than 1 year, nearly 1 year. Yeah. Okay. So even neoadjuvant chemotherapy can result in a complete response 30 to 40%. But however, the durable response or the consideration renal function, so some patients is not eligible for chemotherapy. So I think the IO may have the low for the neoadjuvant treatment for UC. And this recently published last month, JCO, about the pembro for the neoadjuvant therapy. So they have 3 cycles pembro. If it doesn't work, DD and back. If it works, cystectomy. Yeah. So finally, 42% PT0, complete response, no more tumor after the radical cystectomy. And this shows that tumor mutation burden will decrease after IO treatment, and PD-L1 expression will increase after the IO treatment. This is the complication. And hypothyroidism in our series around 10%. And some patients have the liver function impairment, but the complication IRA is very low. And this is for the atezo. Only 2 cycles, then surgery. So totally, nearly 30% have the PT0. But if PT1 positive, 40%. And IO will downstage in the tumor. TMN will change after the IO treatment. So the same PD-L1 will increase after the IO treatment. CD8 will also increase. So my conclusion, I think it's the exciting time in the treatment of UC. I will tell my students maybe radical cystectomy will become rare and rare. Yeah. And reliable predictive biomarker is still pending. And I think the IO is well tolerated and active treatment for UC patients. And neoadjuvant ICI can safely administer in patients with